Lichen planus is a chronic inflammatory disease of unknown etiology, and clinically there are shiny, violaceous, itchy, flat-top papillary lesions, and histologically there is liquefactive degeneration of the basal layer and band-like infiltrate in the dermis. It's more common in the Asian countries. Skin lesions subside in 50% of cases uh, in about 9 months and 100% by 18 months. Mucosa may be involved, nails may be involved. It's an autoimmune disease. Infiltration of CD4 and CD8 positive cells is present, and familial history may also be present. Clinical types: hypertrophicus, follicular, and as the name suggests, there are different types, and you can appreciate what their morphology would be. Then the mucosal is divided into the oral, perianal, esophageal, genital, depending on which side of the body is involved. This is the typical lichen planus. If you can appreciate, there is a slightly purplish, violaceous hue in it. Shiny, violaceous papillary lesions. Wickham's striae are whitish striae that are present on the skin, especially on the volar aspect of the forearm. This is lichen planus hypertrophicus, which is, you can see there is hypertrophy present in this. Another picture of lichen planus hypertrophicus. This usually occurs on the shins of the legs. Bullous lichen planus. There is a bulla formation, and it is actually lichen planus, and not any other bullous disorder. Bullous lichen planus, another example, you can see the lateral malleolus. Lichen planus present on the penile area. Annular lesion at the shaft of the penis. Cicatricial alopecia, or lichen planopilaris, or follicular lichen planus, and there is permanent hair loss in this condition. Lichen planus at the palm. Since the skin of the palm is a bit harder because of the presence of the stratum lucidum, the lesions are a bit different and maybe a little yellowish in color rather than the typical violaceous hue. Oral lichen planus. Lacy network present. Lichen planus may be present on the tongue as well, giving it a little bit of geographic appearance. In the perianal region, you can see the fibrosis and the yellowish appearance. In the nail changes in the lichen planus, what do you see? That the nails are, there is a growth from the proximal end of the nails that is extending throughout the nail plate. It is called a pterygium. This is the characteristic lesion of the lichen planus of the nails. Koebner phenomenon. Now, we did that in the viral infections as well. Koebner phenomenon means that development of similar dermatological disease at any place of trauma in a person who has that particular disease. Histopathology: disruption of the basal cell liquefaction and presence of abundant inflammatory infiltrate. Hyperkeratosis, hypergranulosis, acanthosis. Immunofluorescence: cytoid bodies and IgM staining positive. Drugs causing lichenoid reaction. There are many drugs which can cause lichen planus-like reaction. Antimalarials, thiazides, isoniazids, NSAIDs, beta blockers, coloring agents. Lichenoid drug rash is like this. It's not the typical lichen planus, and even histology is a little bit different from the idiopathic lichen planus. Steroids, topical systemic, solar and ultraviolet radiation, cyclosporin, azathioprine. Now we come on to the common drug eruptions. Common drug eruptions: erythema multiforme, Stevens-Johnson, and toxic epidermal necrosis. This is a whole spectrum, starting with the erythema multiforme minor. It's diagnosed in 1860, 1950. Most common cause was herpes simplex, most commonly post-disease, post-infection. Increased outbreaks in the immunosuppressed. You can appreciate the typical targetoid lesion present in the erythema multiforme with concentric ring and dusky center and outer red zone. Pruritus burning may be present, usually present on the acral regions, and Koebner is also positive in this condition. Differentials are vasculitis and LE. Symptomatic treatment plus prophylaxis. Acyclovir is not helpful now because it is only helpful when the herpes simplex is already present there. Stevens-Johnson, the mid of the spectrum of erythema multiforme, also known as erythema multiforme major. May continue with toxic epidermal necrolysis. As you can see, two or more mucosa are involved in this. Drugs, NSAIDs, sulfonamides, anticonvulsants, penicillins, tetracyclines, doxycycline, and to some extent, infections, the viral infections. But now the drug is overpowering the appearance of the Stevens-Johnson syndrome. Upper respiratory infection, then in 1 to 14 days, symmetric red macules may develop, epidermal necrosis. 2 or more mucosal sites are involved. Systemic symptoms are present. Differential is 10, Kawasaki. ICU, the patient has to be admitted in ICU, stop the drugs, ophthalmological examination, fluids, electrolytes, infections, have to see for the GI and genitourinary strictures. Treatment is IVIG. Toxic epidermal necrolysis is also known as Lyme syndrome. Women and elderly are more at risk. Slow acetylators are more at risk. Slow acetylators mean those patients who can remove a particular drug from the blood very slowly and not at the regular speed that other people do. So the drug remains more for a longer time in the blood and produces more effects. Mortality is 25 to 50%. Most cases are drug related. Antibiotics, especially sulfa, NSAIDs, anticonvulsants. Risk is highest during the first week. High fever, skin pain, anxiety, asthenia, erythematous dusky macules coalescing, progressing to full thickness necrosis with bulla formation and detachment. Nikolsky is positive in this case. Stevens-Johnson is less than 10% of body surface area. 10 is more than 30% of body surface area. Overlap can exist. Scotton is the scoring for the toxic epidermal necrolysis that is very important for the diagnosis. Differentials are staphylococcal scalded skin syndrome and acute generalized exanthematous pustulosis. This is the Scotton, and according to the prognosis, you have to give 1 point each. Age 40 above, heart rate 120 above, any malignancy, urea level, bicarbonate, glucose. And as you can see, when the Scotton is more than 5, then mortality chances are 90% or more. Treatment, withdrawal medications, prevention of complications, IVIG is very important. Necrotizing fasciitis, bacterial infections, usually mixed. We already did that in the bacterial infections. Sudden onset, edematous skin, painful skin. And since it's deep, so the inflammatory findings are more present on the skin surface rather than the deeper. Another picture. Another picture. Urticaria, it's a skin lesion consisting of a wheal and flare reaction in which localized intracutaneous edema or wheal is formed surrounded by erythema, and that is typically pruritic. Classification, spontaneous urticaria, which is the ordinary one. It includes the acute, intermittent, chronic. Then the other is inducible, which is not present spontaneously but can be induced by physical or any contact. Included in these are the mechanical and thermal and the sweating induced, and other like solar or aquagenic, and then the angioedema and urticarial vasculitis. So there are 4 types. Individual hives can last for as briefly as 30 minutes to 36 hours. They can be as small as millimeters to 6 to 8 inches in diameter, the giant urticaria. They blanch with pressure as the dilated blood vessels are compressed, which also accounts for the central pallor of the wheal. Urticaria is classified as acute and chronic with a time between 6 weeks to 3 months. And when it is present daily or almost daily for 6 weeks, for less than 6 weeks, it is called as acute. This is picture of urticaria. Another picture, which is more like erythema multiforme on the palms. Urticaria, commonly called as hives. Urticaria along with angioedema, which is deeper than the urticaria and is caused by transudation of fluid into the dermis and subcutaneous tissue. Lip and around the eyes are common sites. Angioedema, pathophysiology, increased intravascular permeability. Dermatologic findings, well circumscribed acute cutaneous edema due to increased vascular permeability. Face, lips, extremities, genitalia. It is more painful rather than being pruritic. Clinical presentation, abdominal pain and respiratory distress. Etiology, it's often idiopathic. There are certain medications which can cause angioedema like ACE inhibitors, penicillin, NSAIDs, allergens like food, radiographic media, physical agents like cold and vibration, then C1 esterase inhibitor deficiency. But this is basically, there are two types, hereditary versus associated with the autoimmune disorder or malignancy. Management, airway management, antihistamines, cool compresses, avoid the triggers. For patients with C1 esterase inhibitor deficiency, acute management versus the short term as well as prophylaxis. Androgens are given C1 esterase inhibitor concentrate, obviously for those that have the deficiency of inhibitor. Antifibrinolytics, icatibant, which is basically antagonist of bradykinin. Then fixed drug eruptions. Fixed drug eruptions are those that occur at the same time, same location, every time a particular medication is used. And it begins as an erythematous edematous plaque with a grayish center or frank bullae, and then progresses to dark post-inflammatory pigmentation. Common sites are the mouth, genitalia, face, and acral areas. Most common disease, the drugs causing fixed drug eruptions are phenolphthalein, tetracyclines, barbiturates, sulfonamides, NSAIDs, and salicylates. This is a picture of fixed drug eruption. We can see that there was a bulla which has ruptured and the color is typical. Another fixed eruption probably caused by donatol, which is type of androgen. It is characterized by an edematous plaque with a bullous center. Thank you. Okay, this second lecture today is vesicular bullous disorders. Vesicles are small fluid-filled areas less than 0.5 centimeter in size, and bulla is a large. Classification of the vesicular bullous disorders, congenital inherited disorders, and then neurological. The congenital inherited include epidermolysis bullosa, which is included in your syllabus. There are other two as well. You don't need to go for that right now. Immunological ones are the intraepidermal, that is the pemphigus, the subepidermal, that is the bullous pemphigoid, linear IgA, EBA, bullous SLE, and dermatitis herpetiformis. Now, pemphigus comes from the word pemphix, which is blister. Variants of pemphigus, pemphigus vulgaris, vegetans, foliaceous, and erythematous. Pemphigus vulgaris is the most common type, and it is caused by autoantibodies desmoglein 1, which are present over the desmosomes. Desmoglein 3. Pathology, suprabasal split, row of tombstones. The basal cell is attached to the basement membrane, but separate from one another, and acantholytic cells are present in the blister cavity. And since this is a suprabasal split, so vesicles, the bulla do not remain intact. Oral lesions are present in all cases, and other mucosal sites may be involved. Predilection for scalp, face, axillae, groins, pressure points, flaccid blisters with clear fluid later becoming turbid and rupture to form erosions. Nikolsky sign is positive, that is, firm sliding pressure separates the normal looking epidermis from the dermis, and bullous spreading sign, which is also called as Aspo-Hensen sign is also positive. Okay, conjunctival involvement may also be present, as you can see in this picture. Mucosal involvement, erosions present. Mucosal involvement again, erosions are present. Cutaneous lesions on the palms and soles because of the stratum lucidum, the bulla are denser and firmer. Cutaneous lesions, erosions are present more commonly. Then pemphigus foliaceous. It is a type of pemphigus in which there is the level of split is just below the stratum corneum. So the blistering is not obvious, it's just scaling. And this type, the pathology is in the desmoglein 1. Upper part of the body is involved and the mucosae are spared. Pemphigus erythematosus is an overlap between pemphigus foliaceous and lupus erythematosus. Lesions are present, erythematous scaly, nose cheeks, butterfly distribution, and the lesions present over the trunk are similar to pemphigus foliaceous. This is pemphigus erythematosus. Pemphigus vegetans is present in the flexures. Paraneoplastic pemphigus because of underlying malignancy, then the drug-induced pemphigus due to penicillamine, penicillin, captopril, enalapril, cephalosporins, and the rifampicin. This is a immunofluorescence of pemphigus vulgaris. You can see the chicken wire appearance or the fishnet appearance, and in the pemphigus foliaceus, the upper part of the uh, epidermis. Then in the bullous pemphigoid, we will do that later on. So, okay. So in the pemphigus foliaceus, the lesions are present on the upper end. So the immunofluorescence shows subcorneal immunofluorescence. Then the pemphigus vulgaris shows the suprabasal immunofluorescence. This is an emitted picture. Treatment of pemphigus: corticosteroids, pulse therapy, oral regime, then steroid-sparing agents like the azathioprine, cyclophosphamide, cyclosporin. Bullous pemphigoid, second type. Blistering disease of the elderly, tense large bullae are present. Etiology and pathogenesis not well defined. The drugs are penicillamine, captopril, antipsychotics, aldosterone antagonists, and there may be familial history. Subepidermal blister. So the bullae are firmer and denser. Dermal inflammatory infiltrate with eosinophils, neutrophils, and lymphocytes. Clinical features: urticaria or eczematous rash, then development of the bullous lesions over them after weeks to months, dense dome-shaped up to 7 centimeters in diameter. Flexural aspects of limbs and abdomen remain intact for several days. General condition is good. Bullous pemphigoid, you can see the eczematous and urticarial lesions as well as the dense bullae. Same. Topical steroids, systemic steroids, but we don't need that much high dose like pemphigus vulgaris, and dipsone may also be given. Now there are differences between pemphigus and bullous pemphigoid. Middle-aged, elderly, placid and tense, remains intact for short time and longer time. No other lesions preceding the bullae, but urticaria and eczema may be present, and general condition is deteriorated, and it is good in the pemphigoid. Dermatitis herpetiformis, rare condition, intensely pruritic, chronic, recurrent, papillovesicular. It has vesicles. 20 to 50 pruritus first, predominant symptoms. Early lesions may be papules, vesicles, or group vesicles. Extensive aspects of body, gluten-sensitive enteropathy may be present. Then epidermolysis bullosa. This is how a patient feels. And these are basically, this is known as the butterfly disease, and the patients usually are children, and they're known as the butterfly children. Like the butterfly is very delicate and can be, we can break the wings very easily. It's a rare group of disorders in which the skin blisters on reaction to minor injury, heat, or friction. 4 main types, multiple subtypes. Then infants and young children are affected, adolescents and early adulthood. Physical activities such as learning, both genders and ethnic groups are affected. Primary indications: eruption of fluid-filled blisters on the skin, commonly on the hands and feet in response to friction. Blisters can also develop in other areas of the body depending on the type of EB. Blisters heal without scarring in most cases. Blisters, you can see the deformity, loss of fingernails and toes, internal blistering, hyperkeratosis, scarring, alopecia, atrophy, atrophic scarring, milia, dental abnormalities. EB is usually inherited, 2 modes of inheritance. Random mutation can also occur. Over 10 different genes are present. Modes of inheritance: autosomal dominant, autosomal recessive, spontaneous mutation, when there is obviously no parent, neither parent has EB, and the child has the dominant form of EB. It is quite common, 20 newborns per million live births. Both genders affected. There are 4 types. Epidermolysis bullosa simplex, then junctional, then dystrophic, and the acquisitive. Simplex is most common type, usually fairly mild, begins at birth, early infancy, often affects palms and soles, autosomal dominant type. Faulty genes, keratin production, which is the fibrous protein. Junctional, more severe form, may be apparent at birth, autosomal recessive inheritance. Faulty genes have the formation of anchoring filaments called heavy desmosomes. Tissue separation and blistering is present. Severe forms of junctional EB can lead to death before 2 years of age. This is a child who's having this disease, and it's given a picture. You can just go through it. How terrible the life must be for this baby. You can see all these. Then the dystrophic EB, mild to severe variety, 25% of EB is the dystrophic variety, apparent at birth or during early childhood. Faulty genes are in type 7 collagen. Can be dominant or recessive both. Arm and hand contractures, internal blistering, fusion of fingers and toes, possibility of skin cancer at early age may be present. This is an animated picture showing the different levels of the EB where the fault is present. Epidermolysis bullosa acquisita, which means acquired, and it occurred maybe occurred due to immune system issues mistakenly attacking the healthy tissue. Usually occurs attacks the type 7 collagen. It may be associated with Crohn's disease, inflammatory bowel disease, may result in nail loss, milia, and scars. Complications, secondary skin infections, sepsis, deformities, malnutrition, anemia, eye disorders, death, constricted esophagus, hoarseness, skin cancers. Now, laboratory diagnoses are required for diagnosis. Skin biopsy under microscope to reveal which layer of skin is involved. Genetic testing, this has to be done obviously in the early phases to see determine the diagnosis. Skin care to prevent discomfort because palliative treatment is important. We have to prevent the infections from blisters, puncture the blisters, soak wound with disinfectant, surgery to correct the deformities, contractures, surgery to dilate the esophagus, implantation of a gastrostomy tube for improved nutrition and weight gain, physical therapy, gene replacement, bone marrow transplant, and recombinant protein therapies are basically the actual treatment. Prevention and care, it's not possible. The goal is to prevent the blisters from forming by handling your child gently. Keep the child's skin lubricated. Be careful when applying dressings and avoid adhesive bandage or tape. Avoid hard surfaces and rough materials. Trim the child's fingernails regularly. Keep the temperature in your home cool and steady and humid, moist. These are basically special child, and you have to be empathic when dealing with these children. Because if you consider yourself or your children or your loved one in this state, then only you can understand what the child must be going through. Thank you. This was just a little, I liked it from the internet. It's not actually related, but these are the gummy bears that we have seen you all eat. And I liked it because it shows the genetic inheritance pattern. So just add it like that. Thank you.